The speaker is going to be Kate Saunders, also at the University of Oxford. She's going to talk about rough path theory in a different context. And the title of her talk, Finding a Rough Path Through Disruptive Innovation.
When does she finish?
Okay. 25 minutes.
Thank you. It's great to be here. Thank you for inviting me to speak. I'm a psychiatrist, so I'm not ashamed to say there's very little mathematics in this talk. But in a sense that's deliberate because I certainly have no expertise in the area. What I want to put to you, I suppose, is the challenge that I face day to day in my clinical practice, and kind of thinking about how we can move that forward and use, I suppose, cross-disciplinary approaches to do that. And I think as an aside, it's fantastic that meetings like this kind of happen where you've got people from lots of different disciplines, because actually there's lots of complementarity in what we're all doing, and yet whilst we sit in our little departments, actually we don't get a chance to talk about those things. So it's been a really great day, and I've learned a lot, both listening to the talks and indeed just chatting over coffee, where often you know ideas come about. So there's been lots of developments in psychiatry in the last, I suppose, 50, 60 years. We think probably genomics is getting there. We're about to start to see treatments developed on the basis of people's genetics and genetic hits related to specific disorders. There's certainly been some successes in neuroimaging, although probably not that match up to the hype, and certainly the cost has been astronomical. And Alzheimer's is probably one of the few of our disorders where we have a really kind of clear understanding of what the neuroimaging means. And indeed there's this emergent field of immunotherapy, so there are a number of disorders that relate to autoantibodies, but they're rare, okay? They're a very small percentage of our total disorders. And fundamental to our kind of challenge is this issue, which is our diagnostics are still stuck in the 19th century. They have not changed since this chap, Emil Kraepelin, sat down in his inpatient environment and made very detailed notes about the patients that he was seeing. He was extremely observant. One can't criticise him at all, but actually we really haven't moved on much since then. So this is an example of one of his early mood charts. So you can see him mapping mania and depression in red and blue respectively, and in fact we've been largely stuck with that approach. And what makes it sort of additionally difficult as a psychiatrist, I am totally reliant on what patients can recall about their mood states and experience. I have no sort of blood pressure or blood tests that I can do. It is a question of me asking the right questions and interpreting the answers I get back. And that's actually a real problem, because I can assure you none of us remember how we felt last week all that well. We can remember bits of it if something dramatic happened, but actually we're not particularly accurate in our recall. If you're feeling lousy just now, or you're feeling a bit tired, it's been a long day, that's really going to influence how you say you felt last week as well. So it's a real challenge when we're reliant on this kind of self-report. And sort of in response to this, and with the emergence of technology, we've started to measure things in a bit more detail. And really that has come about because of the emergence of smartphone technology, which enables us to do things in real time and ask people in the moment how they're feeling rather than rely on self-reports. It does, of course, give us access to all sorts of additional data too. And we can start to get a means of quantifying the lived experience of patients with mental illness in a way that we have never ever been able to do before. And one of the reasons of my sort of title was this has been described as sort of disruptive innovation in the health space. This is Tom Insel. He headed up the National Institute for Mental Health. He now works in a startup called Mindstrong, and they are sort of interested in how we can use this technology to really change the way we do psychiatry in the 21st century. And that's quite disruptive, because actually most psychiatrists are a bit scared of that. They don't quite know what it all means, and they're kind of quite happy in their sort of safe space of understanding things. And yet we really need to disrupt that if we're going to make a difference for patients. And of course, when we get this data, it's a real challenge for us, isn't it? It's sequential in nature, and actually there's lots of valuable information that our sort of standard techniques would largely get rid of. So missing data, what do you do with it? Well, you either just say there's too much, we'll abandon that data set altogether, or you choose to put some data in its place instead. Well, that's kind of losing information. That gap in the data may be really, really important, mightn't it? And the order in which that information comes to you is also something you don't want to lose, and yet our summary statistics don't give you any sense of that at all. There's often contradictory reports in our data, so people say they feel both happy and sad. How do you interpret that? How do you manage that mathematically? It's quite common actually that it's called a mixed state, but actually to quantify that in any meaningful way is really quite difficult if you use the ways we would normally do. There's no consensus about how you do this at all, and I think really quite importantly, as most psychiatrists like me, the last time we did any decent maths was at A level, and then we just get taught our standard statistical kind of summative stuff, and that's really where we stop. And clearly those methods aren't going to be useful in what we want to be doing today, using this kind of time series data. So I'm going to use an example of where we've begun to think about this in a different way in collaboration with Terry and Imanol in Oxford. And this was a study that we completed a couple of years ago, the automated monitoring of symptom severity, terrible name, but we were not very good at acronyms either. This concentrated on two disorders, bipolar disorder and personality disorder, and whether we could distinguish them. And I've just put this quote up because I wanted to sort of highlight the importance of getting the diagnosis right. This is an old quote, but actually attitudes towards people with personality disorder have not changed at all. So actually getting the diagnosis right or getting it wrong has huge implications for people. Just to give you a sense of what it's about, it affects about 20% of people coming into outpatient clinics to see people like me. Depending on your study, anywhere between 2 and 5% of the population might meet criteria for the disorder. It's often associated with early childhood problems, but actually we know that that's not particularly specific, and it tends to affect women more than men, or at least women are more likely to seek help. What do patients with this disorder kind of present with? Well, they tend to be people who are quite sensitive to interpersonal situations. They have real difficulties regulating mood. It's associated with a lot of recurrent sort of self-harm and suicidal gestures, and they describe an uncertain sense of self, not knowing who they are, that changing depending on who they're with. And because of this changeable presentation, actually self-report's even more challenging in this group, okay? Many of these symptoms overlapped with what you might experience as being an adolescent. I certainly know my mood was a bit unstable. I wasn't quite sure I was a bit impulsive. So you've got this real problem with the overlap with normality and not wanting to overdiagnose. People often present when they're at their worst, so that gives you an added level of complication. And it overlaps with other diagnoses. And that particular diagnosis is bipolar disorder, which is characterised traditionally by this idea of episodes of depression and mania, but actually mood instability is much more common. And if we stick with our diagnostic criteria, so we go back to Kraepelin, we've got a problem. So even if you're a really thorough psychiatrist and you take a really good history, things overlap. So here you've got the criteria for borderline personality disorder here, and then which of these symptoms actually occur in the 3 poles of bipolar disorder, okay? And you can see mood instability is common in both, impulsivity is common in both. People when they're low also become quite suicidal, brief psychotic symptoms can be common, intense anger. So even if you are the most thorough doctor in the world, you've still got a problem because your diagnostic criteria don't help you out either. And this is borne out really in the data. So actually 40% of people with a personality disorder have previously been given the bipolar diagnosis. 20% of people with PD actually have a bipolar disorder when you go back and take a decent history. And even if you use one of the best known validated screening tools for bipolar disorder, it performs really poorly, okay? So actually a third of people have actually got personality disorder, and only 1 in 4 of those screening positive have got bipolar disorder. So a real mess, and definitely no good for patients who need to get the right treatment in a timely manner. So this was the study that we did. We took 48 people with bipolar disorder, 31 with borderline personality disorder, and 50 healthy controls, because actually we don't know much about healthy behaviour either. We assume we do, but I think it's always good to stick a healthy group in, because what we call pathology is based on some quite false assumptions at times, so I felt it was important we did that. These people were recruited from community settings, so they were not people in crisis, but they were people with a known diagnosis. Okay, we didn't link any of the data collection to standard care. We didn't want that to sort of influence treatment as usual. And we didn't really show them their data either, because actually we were a bit worried that if they saw it, people would change their behaviour on the basis of it. Now that might be a good thing, but first off you really need to know what that behaviour is, don't you, and what the pattern of the illness is before you do that. We got them to fill in daily mood ratings. So this was, we gave them all a smartphone, and they completed a very simple rating of their mood. Okay, so dead easy, took about a minute to do. Really good compliance with this actually. These sorts of compliance figures for psychiatric studies are extraordinary. It really doesn't happen like this most of the time. So 80% of people completed ratings, or sorry, of total ratings we had 80%. And more than 60% of our cohort continue to give us data beyond a year. Just think about that. Daily mood ratings for more than a year. I don't think there's a data set in psychiatry that's that considerable, actually. Much richer data set in terms of the lived experience than we've had before. Just as an aside, we also gave them a whole load of other kits, so there's lots of other data streams I'm not going to talk about today, but we gave them actigraph, we looked at their heart rate and things as well, just to get a really good sense of some of the underlying physiology too. I'm not going to say a great deal about the analytics because I'm not the best to talk about it, but we took 20 consecutive data points, so we didn't worry about missing data, we just took the 20 data points and put those into bins of 20, okay? And that gave us just over 2,000 streams of data. The data was normalized, a sort of 7-dimensional path was created, and then random forests used to learn. So this is what it kind of looks like. So if people reported repeated anxiety, so high levels of anxiety, you get a path that looks like this. Here they're sort of reporting a reduction and it's sort of staying about the same. And then if they're reporting stable low levels, you get a downward trend. Does that make sense? So here's where it's changing most. This is actually in some senses stable. Okay, so stable low, stable high. What of course this method also allows you to do is plot a path which shows the interaction between different mood states. This actually intuitively makes a lot of sense to patients and certainly to clinicians, but we've really been able to quantify this in any great way before. And it's kind of really interesting to think about the order in which different mood states change, because that's actually really important information. So we looked at to see whether we could actually predict which group our participants fell into. Actually, we did pretty well at that. So 75% were correctly classified overall. Okay. And that's actually much better than clinicians and certainly much better than the standardized screening tools that people are using. If you remember, only 1 in 5 had bipolar disorder using the MDQ, which is the validated measure. It also enabled us to plot where people fell on a spectrum, and in some ways to me this is the most interesting way of looking at the data, because you can see here we've got a sort of triangle with each of the disorders. So this is where the healthy people mapped, and they're very, very tightly into this corner. So healthy people's patterns of mood or signatures of mood are very consistent and can be found to be much like each other. This is the bipolar lot, where you see a much greater spread. Now that comes as no surprise, because bipolar disorder, if you think about it, has periods when people are well. So actually it doesn't surprise me at all we've got this overlap into the sort of healthy range. That actually makes intuitive sense, but it does give you a much greater sense of the sort of dimensionality of the disorder rather than it being a sort of strict category. And then it's interesting that the borderline personality disorder group look nothing like people who are healthy. They are really quite distinct again. We have questioned whether we got 1 or 2 diagnoses wrong, and I think I'm quite accepting of that possibility, that actually there were a few people in this group that were misclassified clinically, and actually their data suggests they should be in another group. And I think that's one of the challenges is for us as a profession, is actually this data might be, and almost certainly is going to be, more accurate at clustering similar things that look similar than actually Kraepelin was and some of our traditional methods of diagnosis. And I think that's a real challenge for the field as to how we balance that potential sort of challenge to our diagnostic criteria and yet maintain some sort of common language so that we know that we're talking about the same disorders. We did also look at predicting the future, because one of the challenges for us in psychiatry is actually getting in early, intervening early before someone becomes unwell, before they harm themselves, before they need to come into hospital. And if we can find a method of doing that accurately, that could be hugely powerful to patients as well, because if they know they're becoming unwell, they can act to do something differently too. So this is what we did. So if we look at the 3 groups, the blue is healthy, so they're the most predictable. That shouldn't come as a surprise given what I've said about them already. So about 98% of our predictions were correct, between 89 and 98 for the different mood states. If you look at the bipolar, it drops down to sort of in the region of 80%, but that's still much better than chance, isn't it? Still pretty good, actually. And then you get to the borderlines, where it's about 70%. You can almost categorise these groups on the basis of their, how accurately one can predict their future mood. But I would put to you that even 70% is more informed than somebody who's got no sense of how they might feel tomorrow. And for people with personality disorder, that's exactly what they say. I have no idea how I'm going to feel in the next few days. No idea at all. I wake up and it happens. So actually, this could be hugely helpful. Okay, it's not going to be accurate all of the time, but it's a much better flavour of what might happen compared with what they've currently got. We also looked at whether you could predict it into the future as well, because clearly predicting tomorrow might be relatively easy. What can we say about 10 days on, whatever? Perhaps not a surprise that our prediction accuracy drops as you move into the future, but actually still for healthy people, it's not bad at all, okay? It drops a bit for bipolar and indeed for borderline, but it's still considerably better than chance. And actually, if you just present this information and say, actually, well, there's an increased risk of you becoming unwell in the next few days, that's still important, isn't it? I don't think we have to say it has to be that certain, but actually giving people as much information as you can about where their mood state might move to is still clinically extremely important. So I want to put to you that actually the signature model has given us an effective way of distinguishing these three groups. It's certainly more accurate than any of the previous metrics people have used. And this clear overlap that we've picked up actually is very consistent with my clinical experience and makes a lot of sense. It also tells us something about the nature of personality disorder being a valid and distinct diagnosis. There's a lot of people in the field that would argue that that's not the case, but I think actually this data suggests the opposite is true. It's actually very clearly different from people who are well. Now, that's just one study. It's a small number of people. It needs replication, but I think it's fair to say that these findings are promising. And I suppose I kind of think it's important to say we need greater collaboration actually outside of our fields so that we can really maximise the impact of some of these new data streams coming off patients. Most of our studies are done on tiny, tiny numbers. This is actually quite big in the field. Most of them are done on sort of 10, 20 patients over time. We need to really scale that up and actually have a much more robust way of looking at it. I want to just end though with some comments from patients, because actually this is what in the end what all of this from my perspective is about. It's about improving the patient experience. And I think one of the concerns I had sort of setting out on this journey was actually what are patients going to think about the idea of their data being used, giving us all this data? What impact does that have on them? And I think these were just two examples of quotes we got from people really about how they found this idea of monitoring extremely helpful. It made them think about their mood states. It empowered them. It gave them a way of quantifying their lived experience that they didn't feel that they'd had before. And I mean, I just found that really quite moving that instead of my assumption that people would hate giving us data, that actually it's something we can collaborate with our patients, you know, to inform their care in a much more detailed way. So some acknowledgements. Clearly, as I said, I'm not a mathematician, so I have to extend huge thanks to Emmanuel and Terry who've really led on the analysis of this data, but also a lot of colleagues in the Department of Psychiatry doing these sorts of studies with patient groups is challenging at times, very rewarding, but takes a lot of effort. And I think the most important people to thank are, of course, the participants that give us their data, because without them we couldn't begin to actually unpick the sort of more detailed nuances of these mental health conditions. So thank you.
Any questions? Yes, over here.
I have a comment. In 2014 there was a PNAS paper under Liam Hood et al., so you can easily find it. They detected early warning of the onset of depression, and it was 4-level score of emotion, self-assessment. And there is database of Belgian clinical study, 120 individuals, where you can probably similarly apply your methodology. But it's similar approach, just based on autocorrelation.
Thank you.
Any more questions or comments? Yes, everybody.
You could have a perfectly healthy person who was having a row with their boss and having mood swings.
Yep.
Is the analysis capable of picking that and filtering it out?
So we do have actually a lot of data on context as well, because you're absolutely right. The context becomes really important, doesn't it, in terms of interpreting the data. So that's something we want to do in a bit more detail. Actually, there's another data set where they've done that in healthy people from France. where 58 SEC, I think it was called, where interestingly regulation of mood in healthy people, in relation to your argument with your boss, there's almost a natural homeostasis to it, whereas if people are unwell they don't have that. So that was they have very little phenotyping on that population. As I say, it's a huge sample, but they don't know much of the detail of those individuals. They've just sort of people who signed up to do it. So it's a really interesting question, actually, because I think you're right. How people respond to those situations may be very, very informative.
Yes, at the back there.
Does providing people with the ability to monitor their mental health actually in and as itself help them with their mental health?
Yes. So one of the downsides of this study, or it's not a downside from a patient perspective, it was a downside to me, was that the bipolar group we'd got weekly ratings for some years prior, before we gave them all this extra kit. And they look as if they got quite a bit better actually for wearing it all, which is great for them, a bit more annoying for us that kind of wanted a few more manic episodes. So almost certainly it does help. I just got some really interesting feedback from people saying, well, I never believed you when you said when I got pissed that my sleep was worse and I'd be in a more irritable mood. But now actually I've generated the data, I'm going to have to believe that. Which, it's very useful actually, and we probably should be doing a lot more of it. I think one of the challenges is a lot of doctors just don't know how to interpret the data or what to do with it when they see it. Whereas I think it's great.
Do the patients know how to interpret it?
So they've got some, no, I think some of them have, some of them haven't. We've certainly got people who will download their own data and play around with it. I think that's a really important area, is how we present these things. So not presenting it as too black and white, I think. I think it has to come with lots of caveats, because one of the risks, I think, here is that there are certain outcomes, let's say a completed suicide, where actually you're going to have to be really careful about the information the predictions that you're making and how those are used clinically, because getting it wrong once is clearly a catastrophe. So yes, I think how we present this data is a whole other big question that we need to address.
There's one question at the back.
You asked people to assess their moods on a numerical scale. Had you given them any guidance on what those numbers might mean, or did they just decide for themselves when they were feeling 1, 2, 3, whatever?
So we said sort of the top end of the scale was the most angry you feel, the bottom the least, but within that, no. Individuals chose to. Yes, I think it's one of the problems with self-report anyhow, is there's lots of between individual variation, and that's potentially a problem. But I think if you've got data for individuals over long periods of time, you can then start to think about individualizing that analysis. That's the idea, isn't it? But we'd like to be doing this on an individual basis as well.
But did they do that? In other words, did they actually report everything between 1 and 5? Or did you find some people who just said, 2 means awful and 3 means great, but never gave any other scores?
Certainly within the clinical groups, lots of variation. The healthy people, less so, but I guess you'd probably expect that. With all of these scales, that's a problem.
So you have some reason to believe that they're uniform scales.
Yeah, but of course you can't really know what's worse until you've experienced worse, can you? So in a sense, you're always in that difficulty.
Okay.
Perhaps one should just point out that this was really demonstrating that you could distinguish between your judgments of the people you selected.
Yeah, so that's a very good point. So clearly I saw all of these patients. That was my clinical acumen that was being tested, I suppose. So I think that's an important thing to say. I guess one of the reasons that replication may become extremely important in this field is actually we don't necessarily know that every psychiatrist says the same, a pear is a pear and an apple's an apple. And actually this is quite a nice way of looking at it in some respects, whether what we're picking up phenotypically is the same as each other. We would hope it is, but as I said, even the diagnostic criteria don't necessarily aid us.
Yeah. And another technical point some people might be interested in was there was barely enough data to do this, and one had to make a choice between bias and error and variance in a way, and we opted for bias. In that we included all the reports from everybody, and to get round that fact, those pictures you saw that were drawn, on each occasion when we put somebody in that triangle, we removed them completely. We did a one-cross validation. We removed them completely from the data, and only use the other data to make the model and to position them. So that is the accumulated effect of doing that with each person. But if we'd taken out enough people to do it without doing that, we'd have ended up with too much noise and not enough information about what the individuals were doing. It really was an example where the amount of data was just enough to get the second order effects visible.
May I also ask regarding the data? It is emotional index, which
Sorry, I
was,
really can't hear. It's my problem, not yours.
the plot was showing emotional index, something like this, varying between 10 and 20. How is it derived? Is it a self-assessment?
Sorry?
The plot of the curve, this one, yeah, this one.
The accumulated emotion. That is one of the emotions. So when they record over their 20 periods, each day or each recording, they produce another 3 units of anxiety, or another 5 units of anxiety, or another 0 units of anxiety. Those are the accumulated anxiety, except normalized, so that the mean returns to 0. And that's a pretty useful way to turn that kind of data into a path.
Okay, good. Are there any more questions or comments? If not, let's thank Kate again.